of the small chapters to get through. And after this, then we'll get rolling into the what I think is the meat of the course, where we actually start talking about some real disorders. All right, so first up today is pain. So we all know what pain is, but there's a reason it exists. Pain serves as a kind of notification that there's something going on with the body, something wrong with the body. So it notifies the brain so that the brain can then be involved in resolving whatever that problem is. It's by definition, it's just an unpleasant sensation or feeling that comes about in response to injury, inflammation, or something that's potentially injurious. Long before the skin would start to get burned, we pull our hand away from a thing because of the heat. So the mechanisms and pathways for pain are kind of complex, but they do come up in patient care because pain is such a common part of so many different illnesses. All right, so there's two broad categories of pain. There's somatic pain. This comes from the skin or the muscles or bones, and it's transmitted to the brain through specialized sensory nerves. And then visceral pain comes from the organs themselves. And because the organs don't really have a mapping into the brain, they have to kind of find a different path. Pain from the organs, instead of coming through the somatic sensory system, actually comes through the sympathetic nervous system. So pain from organs travels along with the sympathetic nerve fibers that come from the sympathetic chain ganglion. So pain can be sudden or short-term, like the classic you stubbed your toe, or it can be chronic and long-lasting. So a person with an autoimmune disease, for example, like lupus, they might have ongoing pain for weeks, months, even years, as the body continues to respond to that inflammation. So somatic pain and visceral pain. So what triggers the detection of pain in the first place are the nociceptors. So noci is just pain, so a nociceptor is a pain receptor. The simplest version of these are just free sensory nerve endings. In other words, they don't have a specialized receptor. They don't have an anatomic structure that turns one change into another. Instead, they're just nerves that kind of have their dendrites stuck out there into the tissues, and they're stimulated to fire by thermal, chemical, or physical departures from normal. So, that could be an acid burn, it could be frostbite, or, physical injury like trauma. Some of these nociceptors are actually triggered to fire by the body's own chemicals. So we all learned that part of the inflammatory response is pain, redness, swelling, warmth, and pain. So in that case, it's these nociceptors are responding to prostaglandin and histamine that are released from our own cells as part of that common pathway of injury or infection. So there's sort of two terms that sound very similar. One is pain threshold and one is pain tolerance. So the pain threshold is really a physiological line. And that's where enough stimulation of enough nociceptors has occurred for the patient to identify that they have pain. They do not experience pain until that pain threshold is crossed. It commonly gets confused with pain tolerance, or how much pain a person endures before coming to medical attention or taking something or changing their behavior somehow to address that pain. So we got those two different ideas. So pain threshold is when we first start to experience pain. Pain tolerance is when we actually do something about it. All right. So pain comes into the CNS via two different pathways that kind of converge in the same path to the brain. So we have myelinated A delta fibers, big long name, but basically that just means that myelinated fibers can send information much more rapidly than unmyelinated ones. So the myelinated A delta fibers are usually called fast pain fibers. So what comes through that system is acute, sharp pain that's very localized, because these delta fibers, they follow the same path as the sensory nerves from the skin do. So you are aware of this kind of pain very rapidly, and it's very localized. You know exactly where the injury has occurred. You know, so for example, if a mosquito stings you or bites you, you are immediately aware of not only that something is happening, but where exactly it is, because then you can swat the mosquito. So that's the fast pain system. Evolutionarily, the fast pain system is much newer. We'll see that we call that the neo system, as we'll see in a minute. Then the other pathway is the slow pain fibers. These are unmyelinated, which means that their information is going to travel much more slowly into the central nervous system, and it's much less localized. In other words, these slow pain fibers, you can't put your finger exactly where the pain is. It usually is a region that hurts. And the pain that comes along with this is either it's diffuse, so it's for a whole region, kind of a dull, burning, or aching pain. You know, so if you wake up with a backache because you slept funny, that's your unmyelinated fibers. You know, it's not like there's one particular spot in your back that hurts, your whole back hurts, or your whole lower back hurts. There are many more of the slow pain fibers than the fast pain fibers. So the fast pain really only comes from the skin and the mucous membranes. All the rest of the body's pain nerves are the slow pain fibers. So these are going to be included in the muscles and tendons, the myocardium, the digestive tract, the liver, the organs are all slow pain fibers. So both of these different fiber pathways, they converge on the spinal cord, and then immediately after entering the spinal cord, they have a synapse, which is important because it means that at that first junction between the peripheral nervous system and the central nervous system, by having a synapse there, it means that the spinal cord can trigger reflex reactions. So like, the classic, you grab something and you don't know it's hot and you let go of it very quickly. That doesn't have to go to your brain and then back down. The spinal cord throws that switch, so to speak, at this first synapse of the pain system. After that synapse, that information goes up to the brain on each side of the spinal cord, so left and right, through the lateral spinothalamic tract. And it's called that because it goes from the spinal cord to the thalamus. And the thalamus for the brain is sort of the intelligent switchboard. Not everything that comes into the spinal cord do we become aware of consciously. It's the thalamus's job to sort of decide what the cortex is going to become aware of. So it filters out the noise, so to speak, and it lets through the things that are important, to survival or activity or those things. All right. So just like the sensory supply to the skin that lets us, have the sense of touch, spinal nerves are sort of mapped to specific areas on the body, and there's a one-to-one mapping between area of the body and place in the brain. So we call that map a dermatome, and I don't think I have a picture of it in here, but basically it's a picture of a person and there are horizontal lines sort of drawn all over it, and each one of those regions is an area that's served by one part of the brain. So at that spinal cord synapse, like I said, a reflex is possible there. There are multiple reflexes, which we're not going to get into, but some involve just one side of the body, like the flexor reflex. If we grab something hot or if something, stabs us in the hand, we pull back. That's a spinal reflex. For the feet, they're a little more complicated, because if you step on a nail, you have to both pull the one leg up and straighten the other leg or you'll fall down. So some of these reflexes actually involve, they can get quite complicated. So from there, from that synapse, they head up to the brain. The fast pain fibers are the newest evolutionarily, so we call those the neo-spinothalamic pathway. And then the slow pain fibers go through the paleo-spinothalamic pathway. So neo is new, paleo is old. So it's just a simple definition there. So I think you can kind of experience the difference between these two pathways. You know, we've all stubbed our toe at least once in our life. And what you notice is that, you know, there's that sharp initial pain that you're aware of practically instantaneously. But then, you know, several seconds or even a minute later, you start to feel that dull, aching pain. It shows you that we have these two separate pain systems in our body. One is very rapid and sort of very brisk. You know, it makes a big effect on the brain. And the other is kind of a slower, longer lasting, less localized pain. So that's the slow system. So we're not aware that we have pain anywhere until it actually reaches the cerebral cortex, that signal. And it has a couple of stops along the way. You know, pain, regardless of the cause, is something that we as the organism need to deal with, you know, as quickly as the degree of pain would warrant. So we want it to not just go to the cerebral cortex, but we want it to activate other parts of the brain too. So that one pain signal kind of gets sent to multiple areas of the brain. So one of those is the RAS. This is the reticular activating system. It's the part of the brainstem that determines how awake we are. You know, if you have suddenly experienced an injury, you know, you want the brain to be awake so that it can deal with whatever that injury is. So the RAS wakes the person up. The thalamus is going to relay that information to the cerebral cortex so it'll enter conscious perception. And then the hypothalamus and the limbic system create the emotional response to pain. You know, so things like the fight or flight response is triggered by sharp pain in particular. The limbic system increases awareness and makes people more sensitive to, you know, what the environment, so they can determine what the cause of the pain is. So by activating these different places, it gives the organism sort of the best chance of dealing with that pain stimuli, whatever's causing that injury, in as intelligent a way as possible. So here's sort of that diagrammatically. You know, you have stepped on a nail, and that trauma to that tissue triggers the nociceptors to fire. They send their signal up through the sensory branch of the nervous system, so through the dorsal ganglion. There's a synapse here, and we're going to talk more about this synapse in a little bit when we talk about pain management. But from there, it crosses to the other side of the spinal cord and then goes up through the lateral spinothalamic tract. And this is where the signal enters multiple places. So like it's going to hit the RAS, it's going to hit the limbic system and the hypothalamus. It's going to go up to the thalamus to be relayed, and then eventually we'll become aware of it when it reaches the cerebral cortex, particularly in the parietal lobe, which is where the sensory cortex is. So we have kind of this long path. All right. So we know how the pain information gets from its beginning point to its end point, but we really don't understand entirely how pain works. You know, so all we really have right now is a kind of theory based upon you know, what people have observed in how the pain system works. So the theory your book uses is called the gate control theory. And the idea here is that, you know, if you think of the pain pathway as a wire, that wire has switch points where it can be turned on or turned off. So normally the gates are open. In other words, the information can very easily pass up into the brain. But it doesn't do us any good to continue to suffer pain if it's like ongoing. So the body has to have a way of turning pain down or turning pain off so that we can actually deal with whatever the cause of the pain is. So the idea here is the gate can close across that pain pathway and block the pain signals from then reaching the brain. So there are lots of ways that we've learned that we can close those gates. You know, the classic, you know, you stub your toe or skin your knee and you're little and your mom says, well, just rub it a little bit. That actually does something, and that's when you stimulate the touch receptors around that area of pain, that helps to close that gate. So it actually reduces the experience of pain just by stimulating other areas around that. Other methods, applying ice does the same thing. It activates the sensory neurons around that site of pain, which helps to close that pain pathway. Distraction can also work. We do this in pediatrics all the time. We try to keep the kids, mind somewhere else when they're about to get a shot, because, the more you're aware of what's going on, the more open those pain pathways are. So playing a major role in that gate control mechanism are the endorphins, particularly the endogenous endorphins. So that just means our own. Endogenous, we make our own endorphins. So endorphins are a class of chemicals. The most famous ones are the opiates. So this is like morphine, opium, and any of opium's derivatives are all endorphins. And it turns out that our body produces chemicals like this on its own. So the neurotransmitter that's most important for the pain pathway is called substance P. Not a very creative name, but nice and easy to remember. So substance P is what is released by that afferent neuron. So, you've got a free nerve ending that's been disrupted, and it sends its signal into the spinal cord. The other end of that neuron that triggered is going to release this substance P. That substance P then crosses that synapse that we talked about and then activates the neuron that's going to send the information up into the brain. So the opiates actually block the release of substance P from these neurons. So essentially, they close the gate on that pain pathway. So the pain that information about pain doesn't go anywhere because that substance P isn't released. So the next neuron in the chain doesn't know that there's anything happening. And I have highlighted here that opiates are probably the best analgesics. In other words, they will stop pain. They will take the patient out of pain and leave them not in pain. The danger is that they don't do anything about the cause of the pain. So one of the things that people run into trouble about is, a patient presents with pain of some kind. You treat the pain and the patient now feels fine, but you don't have now any information about whether that injury is still going on. So the classic example is like an appendicitis. Somebody comes in, they're in terrible pain because their appendix is inflamed, and you give them, morphine, for example, and they say, okay, well, I feel much better now. But now you don't have any way of knowing if they're getting better or worse in terms of their presenting problem. Is the appendix going to rupture? Well, if you have too much pain control on board, you'll never know that that's happening because all the pain receptors are blocked. So just remember that these are good medicines, but they just block the experience of the pain, not its cause. All right, so here's sort of that in pictures. So here's the gate open. This is the way things are most of the time. So painful stimulus triggers this nociceptor to have an action potential. That action potential travels down and into the spinal cord. Substance P is released at this synapse, and then it's the substance P that triggers the upward neuron, or the ascending neuron, to bring that signal up into the brain. So that's how things are normally. But we have these specialized neurons. They're interneurons. In other words, they don't have, they're neurons between other neurons, is all that means. And they are the source of these endogenous endorphins. Enkephalin is just one of the endogenous endorphins, so they're using that as an example. So if pain has been ongoing for a time, or if, say activity needs to continue, you're lost in the woods, for example, and you've, fallen and twisted your ankle, your endogenous endorphin system is going to kick in to reduce that pain so that you can survive, so to speak. So that signal comes from the brain. It activates these interneurons. They release enkephalin, or one of these endogenous opiates, and those opiates block the release of substance P from that afferent pain fiber. So essentially, the gate has closed across the system. So now instead of pain information being relayed up, it's being blocked where it enters the spinal cord. So the reason that things like morphine work is they act just like the enkephalin does, just like the endogenous endorphins do. So they block the release of substance P and therefore block the experience of pain. It is what makes them such good pain medicines is they work directly at the nerves that are bringing that pain into the brain. So gate open, gate closed. Yeah.
What kicks those off after a little while?
What do you mean?
Well, like when we give someone a drug, it only lasts for so long. So what kicks those off from blocking the receptors?
Oh, they get metabolized.
Oh, they just get like used up basically. The body absorbs it.
Yeah, the liver is always destroying anything that doesn't belong. Okay. So as it circulates through the liver, the levels go down.
It goes down and
yeah.
down and down.
Yeah.
So there's nothing that like.
Because when we do if we put the anesthetic directly at the site, like into the spinal cord, it lasts much longer. Like you get with.
The liver can't get to it.
Exactly, because the liver can't get to it to bust it up.
Thanks.
All right. So signs and symptoms of pain. Pain is probably one of the most common presenting symptoms in all of medicine. Why do people end up in front of medical care? Because they're having pain of some kind. Now, there are lots of other reasons too, but very, very common. In any doctor's office, any day, you're going to see somebody whose chief complaint is pain of some kind. So one of the things we try to do is we try to get as much information about that pain as we can because it helps us in our diagnosis. So these are some of the classic things that you want to document about a patient who's complaining of pain. So where, location, very important, and description. Description is a lot harder than you might think. Particularly in kids, they haven't had enough experience with pain to really know what to call it. And even in the adult patient who's been otherwise healthy, they too may not have very many words to describe pain. So what we often do is we kind of give them a menu. We prompt them, is it aching? Is it burning? Is it sharp? Is it throbbing? Because particularly a person who's in a lot of pain, they're not going to be able to think up these words very well. So it's good to have kind of your own list in your head so you can help patients describe their own pain to you. So describing the pain itself. Timing and association. What triggers it, what makes it get better, is often a really important diagnostic clue to find out what the source of that pain is. Trying to discriminate bone pain from muscle pain, for example. In bone pain, it hurts even when the limb is at rest. In muscle pain, it only hurts when you're actually doing something. So timing and association. And does it come and go, or is it constant? Physical evidence, particularly in the unconscious person, how do you determine if they're in pain? Well, you have to look at other things because you can't ask them. And the same applies to children, too. So pain has a tendency to increase heart rate and blood pressure. So vital sign changes can be a sign of pain. Pallor and sweating. That fight or flight response is triggered by painful stimuli. So, you get vasoconstriction, so the skin gets kind of pale, and you get sweating as, again, a result of that sympathetic nervous system. Associated signs and symptoms. What goes along with the pain? Nausea, vomiting, dizziness are all good diagnostic indicators for what's going on. Certain kinds of pain trigger a profound anxiety or even fear. So chest pain is one of those things, probably because, we human beings are wired up, such that our hearts are very important to our survival, so we want to know that there's something going on with them. So people who have chest pain are often kind of freaked out and panicked, and that's the limbic system component of that pain. And then body positions. You can tell if somebody's in pain based on, their position. Somebody who's in pain is never just relaxed. They're tense, they're flexed as a rule. Facial expression, they'll guard the area that hurts. If somebody has a broken arm and you come on this side, they'll turn away from you to try to keep that injured area away from further danger. In little kids, again, they have a hard time describing pain. Infants are particularly challenging, because They cry for lots of reasons. But when you've been around kids or babies and enough, you can start to identify the pain cry. And these are just some descriptors. Very tightly closed eyes. They kind of furrow their eyebrows down. And then the classic is the square mouth. If a baby's crying with a big square mouth, that usually means they're in pain or just really angry about something. All right. So in peds, we try to give the kids some tools to use. Like the common one is the faces scale, where there's a happy face and a miserable face and 3 faces in between, just to help document, are we improving the child's pain or not? All right. So organ pain is a little bit harder for the brain because, the brain has a map of all the skin. It doesn't have a map of all the organs on the inside. So referred pain is pain experienced in one place that is actually coming from somewhere else. So some examples of that, like heart pain is referred to the left chest, and the inside of the left arm is the classic coronary artery, myocardial infarction problem. The lungs and diaphragm tend to be felt in the neck. The liver and gallbladder, you can have right shoulder pain with those, which is not a very unusual presentation. You do get that, like with gallbladders, as well as over the site where it actually exists. The appendix can, it just lives right down here, but it can trigger pain in this whole thing. So lots of referred pain sites. The idea or the theory on referred pain is as the nerves from these organs join up, we feel that pain associated with the dermatome of that particular spinal nerve. So not that that's terribly important. All right. So pain tolerance, like we talked about, is the degree of pain the patient endures before they do something, before there's a behavior change, which might involve taking a medicine or going to the emergency room or anything in between. Pain tolerance varies a lot. Pain threshold doesn't. So it takes about the same amount of neural stimulation for all of us to feel pain, but what we do with that pain level is different across people. Some people are very sensitive to pain. Some people, are very resistant to have a very high pain tolerance. There are a lot of factors that come into play here. Culture, family traditions, prior experience with pain can either increase or decrease your pain threshold. And even in a single individual over time, factors can change your pain tolerance. So, like when you're tired, hungry, if you're sick for other reasons, your pain tolerance goes down, so everything feels like it hurts more. So those things can change even in a single individual. All right. So acute pain, sudden, severe, usually short-term. Typically, acute pain indicates tissue damage. In other words, cells are actually being destroyed. And once that damaging agent is removed, typically the pain subsides. It can be generalized, but typically acute pain is localized to one particular place. It triggers the fight or flight response. That's one of the things that the hypothalamus does in response to pain, is trigger that sympathetic nervous system. For some people, vomiting occurs in association with pain. Again, that's probably due to the sympathetic nervous system, the stress response. And then acute pain has a strong emotional response. It can elicit fear, concern, anxiety, all of those. All right. So acute pain is much easier to deal with because usually it's localized and you can very quickly identify what the cause of the pain is. Chronic pain has a kind of life all of its own. So in the patient that has a disease or a disorder where pain is long-term and constant or even coming and going, it can have a profound psychological impact on people. Chronic pain makes people miserable. And miserable people have a lower pain tolerance. So it's kind of a vicious cycle in chronic pain. So sleep and appetite disturbances are common. Irritability and depression. Part of that is, the stress response makes us sort of pain resistant. But the stress response can only go on for so long. So in chronic pain, the pain has lasted longer than the stress response has. So they no longer, the patient doesn't have the support of that stress response in dealing with the pain. So it can be, like I said, kind of a vicious cycle. These patients often require sort of specialized pain management, which we'll talk about a little more in a bit. All right. So your book uses headache as an example of pain, and it's a worthwhile topic because headaches are very common. They're very common presenting illnesses in clinics and emergency rooms and things like that, so it's worth talking about. And there are a number of different types. So the sinus headache is associated, not surprisingly, with congested sinuses. So you have to kind of remember where we have sinuses. We have them in the frontal bone, so just above our eyes, kind of helping to make the shape of our eyebrows. We have sinuses here in our maxilla, and then there's actually a sinus deep in the middle of the brain in the sphenoid bone. So sinus headaches are usually associated with some kind of an upper respiratory infection, but they can occur even outside of that because the sinuses can fill up for other reasons and get increased pressure in there, which is what triggers a sinus headache. Tension headaches don't come from a tense lifestyle. They're talking about muscle tension. So these are headaches that result from the muscles that are in the head, particularly the temporalis muscle, which is at your temples. Some people, under emotional stress, they tighten those muscles, and a muscle that's been tight for a long time will start to ache and hurt. So tension headaches come about from muscle tension, usually as a result of some kind of an emotional stressor. They can go on for a long time, days or weeks. Really, the only way to break the cycle there is you've got to get the person to relax or fix the problem or whatever is the stressor needs to go away. All right. And then migraine headaches are the most complicated of the headaches. It used to be that very little was known about migraines. You know, they were sort of mystical. But now a great deal more has been learned about them, and now we know that it is in fact related to abnormal changes in blood flow to the brain, you know, which isn't surprising because people who have migraines will tell you they can feel their heart beating in their head. And the reason for that is it is in fact an arterial blood flow problem. Essentially, too much blood is getting into the brain, too much pressure. So the meninges respond to that pressure with the intense pain of the migraine. So many migraine sufferers can identify what the precipitator is. In other words, what triggers it. It can be anything, practically. You know, chocolate, red wine, babies crying. I mean, there's lots of precipitating factors. The pain is usually throbbing and severe, usually incapacitating. In other words, you know, they can't finish the day at work, they can't finish the day at school, they have to do something, you know, they have to shut down, so to speak, to deal with the migraine pain. Usually they start on one side and then spread to include the entire head. Classic board question about migraines is about the aura, and an aura is just a feeling that the patient has that precedes the headache. And again, many people with migraines can identify the aura so they know the headache is coming. So it can be hallucinations, not the fancy ones like you see on TV, but just specks of light or sounds that, you know, hearing things that aren't there, and then nausea. Another classic migraine symptom is visual disturbances and photophobia. In other words, wanting to be in the dark. And those two things probably come about, again, because the eyeball, the optic artery, is related to this, to the cerebral arterial architecture. So when blood flows changes occur to the blood flow of the eyes, too. These can last a long time, up to 24 hours. They can go on for multiple days, but most people learn how to treat their own migraines so that they don't go on that long. Oftentimes, it's sleep that fixes it. You know, if you can get the patient asleep for a while, when they wake up, the headache will be gone. They usually end up in quiet, dark rooms because that's what makes the headache at its least. Now that we understand migraines a lot better, there are some new medications that target the actual cause of the migraine, which is that change in blood flow, and they work on the serotonin system. They mimic serotonin, and serotonin helps to fix that blood flow problem. So the only problem with these serotonin medicines is you have to take them immediately at the start of the headache, because they won't stop a migraine that's in full-blown, that's fully on, so to speak, but they will stop a migraine from escalating. So you can stop it before it starts, essentially. All right. The worst of these headaches is the intracranial one, and that means because of what it means. So intracranial headaches come from an increased ICP, or intracranial pressure, which is always a bad thing. You know, the skull is a limited space. It's bony all the way around. So the brain can't expand, so instead the pressure just goes up. And if the pressure gets too high, the pressure itself can actually try to push the brain down through the bottom of the skull. That's called a herniation. So any kind of intracranial headache, and you worry about big bad stuff like that. So causes, anything that takes up space in the head can cause an increase in intracranial pressure. So this can be a bleed, this can be a tumor, this can be an infection, an abscess. Anything that takes up space can cause an intracranial headache. Edema, again, because the brain is inside this bony case, it has nowhere to expand. So if you have generalized edema all over your body, you may end up with an intracranial headache. So one of the classic ones is alcohol causes edema, and it's one of the reasons why the hangover has that big headache, is part of its ICP, elevated intracranial pressure. So we'll talk more about that when we get to our neuro chapters. All right. So what do we do with pain? Well, we treat it. And the medicines we use to treat pain are just called analgesics. They come in oral, IV, or other versions of injected medicines. Typically, we classify them by their strength, so to speak. There are analgesics for mild pain, moderate pain, and then severe pain. So for mild pain, this is what we all have in our medicine cabinets. So aspirin, Tylenol, and the NSAIDs are all in that mild pain category. Downside, they're very effective, particularly the NSAIDs, because they also help to reduce swelling and turn that inflammatory cascade off. But they have some adverse side effects, like nausea, ulcers, and allergies. Very few people are allergic to the NSAIDs, though. The big ones of concern are the gastric ulcers and bleeding, because aspirin and the NSAIDs have some effect on the hemostasis system, or the clotting system. And the NSAIDs in particular turn the stomach's mucus production down, which increases the likelihood that the stomach will try to digest itself, which is essentially what an ulcer is. So particularly with long-term use. And you have people who are on NSAIDs every day for years and years, for arthritis, low back pain. So there are people at those risks. Moderate pain, these are going to be your oral opiates. So codeine, oxycodone. Oftentimes they are packaged in conjunction with these guys. So, there's Tylenol with codeine, for example, or ibuprofen with oxycodone. There's lots of mixtures there to try to combine the two effects. Downside is they do depress respiration, and they are addictive. So, we want to be careful with those. And then for severe pain, these are going to be your IV or intramuscular opiates, like morphine or meperidine. All right. They're a big problem, again, narcotics, so they're addictive. And then these guys can get you in a lot of trouble with respiratory depression, as well as constipation, because morphine slows down the GI tract, and it slows down the drive to breathe. So you have to have patients on a monitor so that you're making sure that their oxygenation is good. All right. Other treatments, pain, particularly chronic pain, it's useful to have more than one kind of agent that you're working with. You don't want to just give out codeine or oxycodone. You want to have some other modality that you're using to treat too. So sedatives and anti-anxiety drugs often go with the analgesics. The idea here, it does make sense. If you calm the patient down, their pain their pain tolerance goes up. So they experience less pain without needing more opiate, without needing more narcotic. So oftentimes the anti-anxiety drugs or the sedative, like Benadryl is very commonly used for this purpose too. It calms the patients down, encourages them to rest and relax, which usually helps the pain to go away too because you're not moving around. So those are good. And then people who have chronic and increasing pain, like a cancer that's untreatable, usually what's done is a kind of stepwise approach. You start with the lowest pain medicine that will work, that lowers the patient's pain enough for them to do their activities of daily living. When that stops working, only then do you go up. So you try to keep the pain medicine as little as possible, essentially. The reason for that is opiates, we develop a tolerance to them. In other words, it takes more and more opiate to get the same effect because the body's response to opiates is to produce more receptors for opiates. So it ends up being kind of a vicious cycle. All right. PCA is very popular today. This is patient-controlled analgesia, and any of you that have worked in the hospital, I'm sure you've seen these. There's IV versions. There's also oral versions. But basically, this allows the patient to decide when they need more pain medicine within limits. It's not you can't just take as much as you want. But the idea here is if you let the patient decide when they need it, they'll treat the pain before it gets bad instead of trying to stop pain that has gotten bad, because it's easier to keep pain from getting worse than it is to take bad pain and make it better. So we use that. There are pain management clinics now because patients are living longer with what used to be fatal diseases or with diseases that cause chronic pain. So they use lots of different modalities. They do massage, distraction, relaxation, physiotherapy. All kinds of stuff goes on in those pain management clinics. And then in the case of intractable pain, in other words, no modality has been able to resolve it, the most severe form of pain management is to cut the nerves themselves. No nerves, no pain sensation. So these are patients who usually are at the end of life or have a problem that they're going to live with for a long time, but they don't need the nerves anymore, like somebody in a wheelchair, for example. This isn't done very often, obviously. So anesthesia is a little different than analgesia. Technically, anesthesia is blocking the sensory nerves that create the pain stimuli themselves. So instead of blocking it in the spinal cord, like that gate control theory, this blocks it at the site at where the nerve endings are. So this can be either local, general, or spinal. So local anesthetic is put at the site where the pain would be occurring. So this is lidocaine, for example, in a wound that's about to be stitched. General anesthetic either involves IV or gaseous medications, and they work by putting the brain to sleep. So if you put the brain to sleep, then there's no brain to be aware of the pain. So those two things go together. And then spinal anesthesia is like local anesthesia, but it's put in at the spinal cord instead. So like your epidural in your OB rotations is a spinal anesthesia. Dull the nerves or turn the nerves off to a region, and then the pain can't get in to the system to be experienced. All right. Okay, so before we do our first question, I'm going to send you the student number question. So 42, 33, 42. 6, 7, 8, 9, 10. All right, jump in there if you're not in there yet.
I'm going to try, this is a new device.
Oh, okay. If it can connect to the web, it should work. That's what they tell us anyway. All right, I got 2 people I'm waiting for.
I put my number in, but it's still.
What number are you?
8, but it says it's still waiting.
I have 8.
Who do you have?
I have 2, 3, 4, 6, 8, 10, 11, 12. So who is not in that list?
Have you not started the question interview then?
Not this one, no.
Oh.
All right, I'm going to end it, even though I only have 8. Email report. Now we'll do a question. Okay. So, pain perceived in the left arm during the course of a heart attack is an example of what kind of pain? Bam, of course everybody got that one. That's A, referred pain. Phantom pain we didn't talk about, but phantom pain happens in a person with an amputation, and because the brain still has a map for that region of the body that's no longer there, they can sometimes experience pain in a limb that is no longer present. So it's a neurologic issue. I didn't talk about it because it doesn't come up very often. You know, we don't see amputations like we used to because of improved antibiotics and things like that, but that's phantom pain. Okay, which of these is a headache related to changes in cerebral blood flow? All right, I think that's everybody. That's all. 8 of you guys are quick. That's the migraine. So the migraine is cerebral blood flow related to serotonin, or at least the medications that we use to fix the cerebral blood flow problem are based on the serotonin system. All right, and that's it for that one. Okay, so let us go on then to environmental hazards. All right. So this chapter, despite what it sounds like, you know, we hear the word environment a lot these days, and what we're talking about is, you know, the biosphere, you know, the water, air, that kind of thing. Your book is using environmental hazards to include not just potential toxins and stuff that are in the environment, but pretty much any non-biological thing that can affect the body and cause damage to the body. So we're using it more in the biologic sense of an animal's environment is everything that can affect that animal. So just to avoid confusion. So there are lots of things out there in the environment that can cause damage to cells, to tissues, to organs. With the Industrial Revolution and the chemical revolution, you know, there's so many things that are now made, you know, using chemicals from petroleum as well as chemicals from other things. There's increasing concern about the potential for dangerous chemicals in our water supply, in our food supply, and in the air. And these, some of these chemicals have been found to be associated with things like autoimmune disorders, vascular disease, certain kinds of respiratory illnesses can all be traced back to man-made environmental contaminants. The hard part is you oftentimes don't know a thing in the environment is toxic until it's been around for long enough to have it stored up in people. For example, DDT was a pesticide. I think it was either a pesticide or an herbicide. But it only causes harm if you're around it for a long time. So it can be a real problem for these. In this country, we have 2 parts of the government that look out for this. One is OSHA, the Occupational Safety and Health Administration. They try to keep the workplace safe and free of harmful exposure. And then the EPA, the Environmental Protection Agency, they are looking out for all the rest of us, not just at work, but in our everyday lives and environments. So chemicals get into the body through food or water. They can be inhaled, and some can actually be absorbed through the skin. Very small molecules and lipid-soluble molecules can get into the skin or get into the body that way. Industrial waste, agricultural waste are two primary sources for potential toxins in the environment. Man-made chemicals tend to behave differently a lot of times than natural chemicals that trees and fungi and bacteria and stuff make. And one of the ways they're different is they don't biodegrade. In other words, they don't break down into less toxic and simpler molecules. They have a tendency to stay complicated and toxic or break down into something that's even worse. Now, a lot of progress has been made in this area. It used to be that the plastics that were in grocery bags and things like that, would break down into something worse than they started with. But now, we're getting better and better at this, I think, in America and humans in general. Of course, we can test food and water for chemicals, but something I've learned just only recently in my career is you can only test for something that you know what you're looking for because of how the chemical testing works. It's not like you can look at a bottle of water and find out everything that's in it. You kind of have to know what you're looking for in order to detect it, which makes a kind of vicious circle because if you don't know it's there, how do you know to look for it? How do you know it's causing a problem? So it's a challenging part for the government and for industry both. So how do chemicals damage? Well, they can cause damage in a single large dose, as can occur with, say a worker in the field gets sprayed with pesticide from an airplane going overhead. That can cause massive pathology. Or more commonly, it's from repeated small doses over time. So the toxins build up, essentially, in the liver and other parts of the body, and then eventually start doing damage when they've accumulated to a high enough concentration. So normally, the liver is a great detoxifier. There are always some toxins in the food that we take in, but the liver has such an enormous potential for chemical reactions. It can make all kinds of chemistry happen. It ends up detoxifying most of any of those toxins that are coming in. And you remember that all the blood from the digestive tract passes through the liver before it goes anywhere else. That gives the liver a first chance at it. So anything that's coming in from food or water, and the liver will probably destroy it before it can actually go out there and do any harm. So chemicals can do all kinds of things. Damage the cell membrane, cause metabolic derangements where a metabolic process gets halted or skips a step, as well as being carcinogenic or teratogenic, in other words, causing birth defects. So chemicals, heavy metals, particularly lead and mercury. All the heavy metals are a problem in too high a quantity, but lead and mercury come up most often. Now, in this country, mercury is tightly regulated, so we don't have a lot of mercury-contaminated water. In other parts of the country, though, or in other parts of the world, rather, mercury is not regulated and continues to be a major source of health problems. There are places in the Far East, for example, where birth defects and neurologic problems from mercury poisoning are very common. Mercury's effects are profound. The term mad as a hatter comes from mercury poisoning, and that's because the hat bands of the old hats in the Victorian England times had mercury in them. So the hatter, the person making the hats, was always touching and working with mercury, and they had a tendency to be a little crazy by the time they got older because of mercury poisoning over the long term. So a little history lesson in the middle of things. All right. So you can get this directly from the water, or you can get it from fish that have been in mercury-polluted water. You eat the fish, you get the fish's mercury, and the same thing happens. All right. In this country, though, it's all about lead. Lead is our major heavy metal contaminant in this country. The reason for that is Lead is used very heavily in industry. You'd be amazed at all the different things that lead is part of in our modern industrial society. It's not just car batteries. It's even stuff like the development of plastics. Lead is part of that process. So it's everywhere. And America is rich in lead. So we have had lead mines for a long time, and our lead industry is very strong. So we end up with lead around, basically. So any place where lead has been produced or worked with before all of the regulation is likely to have significant lead in the soil. We have an area here in Omaha. I know there's a big area in Missouri where there's lots of lead in the soil. We all know about lead-based paint. It was used as paint because lead covers the wall very well. In other words, it's very opaque. It's also used to be used in cosmetics, incidentally, lead did, for the same reason, because it's very opaque. But, so how do we get lead? It's through the food or water. And I added a line here, which you might want to make a note in your notes about. Iron deficiency in human beings creates what we call pica, which is a craving for non-food stuff. So essentially, and we're not the only animal that does this. As mammals, when we're short on minerals, we develop a taste for things like clay or paint or things you'd never think about eating. But in the person who is iron deficient, because they're looking for that iron, which is what they need, they'll end up eating things like dirt and sand and stuff like that. So we call that pica. And it affects children because the iron-deficient child develops pica. Often it goes unnoticed by the parents, and the kids end up eating, like they'll peel paint off the walls and eat the paint to satisfy that pica. So that's one of the connections to lead-based paint. Kids, it's not like kids eat paint normally, but when they're iron deficient, they do, because it has that taste that they're looking for, which is the metal, the iron. So, like I said, yes, in fact, kids do eat dirt when they need iron. All right. There is another association, too, with iron, and that is in the digestive tract, lead will be absorbed in favor or instead of iron. So if there's both lead and iron in the digestive tract, the lead gets absorbed preferentially. It shouldn't be like that, but there isn't enough lead exposure to have had the system evolve correctly. So that's another place that those two things work together. What does lead do? It destroys red blood cells. It creates a hemolytic anemia where the red blood cells pop. Causes ulcerations in the digestive tract. That's called lead colic. We don't see that very much anymore because we don't have the kind of lead poisoning that we used to have in this country. It causes the kidneys to inflame, so the tubules swell. But it's most famous for its nervous system problems. So it causes neuritis, which is a peripheral nerve problem. They demyelinate, so you get numbness and tingling and weakness. Encephalopathy. This is significant lead exposure that you get encephalopathy and seizures, but degeneration of neurons in the brain. It's this last one that's most common, and that's what will appear on your board exams and stuff, is what is lead's major downside for the kids? Developmental delay and intellectual impairment. And it's lasting. In other words, the child with lead poisoning does poorer on the psychological or on the intelligence scales than the child who didn't have lead poisoning. So it's one of the reasons in pediatrics we're always looking for lead. If there's lead in the region, we look for lead in the patients because it has its major impact on kids in developmental delay. So the treatment, eliminate exposure. Sometimes that's extreme. If there's lead in the soil, well, how do you get rid of it? Quite literally, they take the soil with the lead in it away and they bring new soil in. Down to, what is it, Carolyn? 6 inches or?
No, not even that far, like 30 centimeters.
Yeah, so it's
very small.
Yeah, but it's still moving a lot of dirt.
A whole yard, yeah.
So you try to eliminate exposure. You want to get the lead out of the patient. Now this is harder than you might think because lead gets tied up into the bones. As bones are made, the lead ends up getting embedded in the bones. So essentially, kids who've had long-term lead exposure, the lead will keep leaching out of their bones sometimes for years, even after you've taken the lead exposure away. Chelation, these are medications that basically bind lead and then pull that lead out of the body, either through the kidney or through the digestive tract. And then iron supplementation. Because both iron and lead are 2 pluses as ions, they can stand in for each other. So if we make sure the child has plenty of iron, it has a tendency to push the lead out. So it's another way to get rid of the lead. Plus, the iron supplementation fixes the pica, so they stop eating the paint off the wall. Yeah.
You said lead gets digested before food?
No, lead gets absorbed instead of iron. If you have iron deficiency and lead in what you're eating, the lead gets absorbed better. What I was trying to get at is and you'll see it on board questions too, there's an association between iron deficiency and lead poisoning. Those two things go together. So if you have a child in a lead region who's iron deficient, think lead poisoning, because that's what ends up happening. All right. So chemicals, heavy metals, inhalants. Inhalants are a class of chemicals, but instead of coming in through drinking water or food, they come in through the respiratory system instead. So these can be particulates. Particulates are just little specks, small enough to be inhaled. Asbestos is probably the most famous of the inhalant toxins. It causes a rare form of lung cancer. But iron oxide, yes, that's rust. Rust can cause problems in the respiratory tract too. And silica, which is very fine sand, can as well. And all of these things are used in industry. Not asbestos anymore, but it was heavily used in industry. But silica and iron oxide are commonly used. So, and then there's the gaseous. These are true gases. So sulfur dioxide, ozone is fine in the upper atmosphere where it protects us from UV rays, but ozone in our breathing air, too much of it causes problems because it's highly oxidative. And then vapors are usually organic compounds that are in the air. You know, that the vapor is from the liquid. So like carbon tetrachloride is a very common industrial chemical. So where do we find these inhalants? Lots of places. So factories, labs, mines, all exhaust gases from our automobiles are all considered inhalants. All right. So that's the chemical class. So you had your heavy metals, you had your environmental chemicals, and then you had your inhalants. Some other things that can do the body harm that don't have anything to do with chemicals are hot and cold, and then we're going to talk a little bit about radiation. So hyperthermia is what we call it when the body's core temperature is too high. So this can be from an extreme environment. Firefighter, battling a fire is in 200 degree plus heat. So that can very quickly lead to hyperthermia. Any reduction in the ability for the body to cool itself. The classic example, which I'm probably showing my age, but there was a James Bond film where one of the actors was painted gold from head to toe, and the story is that he ended up hyperthermic because he couldn't sweat, so he couldn't get rid of the heat that he was making. Strenuous activity on a hot day. So that's a double whammy. Say it's 110 degrees outside and you're running a marathon. You're increasing your heat production because as muscles contract, they generate heat. And because it's so hot outside, there's very little what they call thermal differential. In other words, it's hard. The air is hotter than you are, so you can't give it heat because it's already hotter than you are. So we worry about people on very hot days doing strenuous activities is all. The key is adequate fluid intake, because even if the air is hotter than you are, sweat will still take heat away from your body. But if you don't have adequate fluid, you can't sweat, and then you get into that vicious cycle. So some of the syndromes associated with heat cramps are just muscle spasms because of electrolyte loss, usually in sweating. Heat exhaustion is where you're starting to see neurologic effects. So sweating, headache, nausea, dizziness, syncope, This is usually from being too hot and not having enough water. So this is what you see most commonly on very hot summer days, for example, or at festivals where there's lots of people out in the heat. You see heat exhaustion. And then heat stroke is this most serious form. So this is shock, in other words, hypotension, coma, very high core body temperature. Normal healthy people don't usually get into heat stroke. It's very young and very old people do. And we talked a little bit the other day about why the elderly end up in this, because they're less sensitive to heat and they have less vasculature to their skin, so they have kind of some risk factors. But we see red, dry skin, headache, dizziness, rapid, weak pulse. So this is the, call the ambulance. This person needs immediate help. All right. So too hot is pretty easy to treat. You cool them down. You give them fluids, electrolytes if their electrolytes are out of whack. But for the most part, the key is cool them down and keep them relaxed. The less the muscles are contracting, the quicker they can get rid of the heat. The opposite end of things, too cold, hypothermia. Frostbite is a localized effect to the cold. So the colder we get, the more vasoconstriction we have. And what starts to suffer is the ends of the body. So your fingers, the tip of your nose, the edges of your ear, your toes, they don't get very much blood when you're very, very cold. And if that goes on for a long time, they not only are not getting very much blood, so they're not getting much heat, so they're getting colder and colder. So essentially, frostbite is frozen tissue that has frozen because of this vasoconstriction together with cold. So the key with frostbite is slow warming. The old, you don't run your hands over in warm water if you have frostbite. You let them warm up all by themselves. And that's because sudden warming thaws the tissue, and then the tissue can die. Because as long as it's frozen, it can't really die, because it's all frozen. So if you thaw it out slowly, the cells can recover as opposed to just being killed. All right. Systemic hypothermia, this is a body temperature that's below normal. Submersion in cold water is probably the most common way that people get hypothermic, and that's because water, it has a high thermal index. In other words, it can take a lot of heat away from you. Inadequate clothing in the winter, or wet clothing on a windy day. Evaporation is a powerful cooling device. So if you're wet and windy, can bring heat away from your body faster than you can make it. All right. So the effects on the body depend on length of exposure, how cold it was. On your way to hypothermia, you shiver first. That's your body's natural heat-making mechanism. Make muscles contract, it generates heat. But when you start to get hypothermic, you stop shivering, and instead you get very tired. You see this in movies a lot of times. People who are stranded in the mountains or whatever, they just want to lay down and go to sleep. It's because that's what hypothermia does. It kind of turns the brain down, and you want to go to sleep when what you really need to be doing is moving more, not moving less. All right. Again, you want to rewarm people slowly. There's an old saying, the patient isn't dead until they're warm and dead, and that's because patients who have been profoundly hypothermic, they can go for many minutes, even 30 minutes or an hour or more, even without a heart rate, and can still recover, because as the whole body cools down, the metabolic demands go way down. So we heat people up before we declare them dead. All right. So too hot, too cold. Radiation. So, we don't see a lot of radiation here on Earth, at least not radiation that bothers us. But there is radiation from the sun. We all know that, UVA and UVB. So you want to use a sunscreen to prevent that low-level exposure. Some industries use radioactive materials in what they do. So like the X-ray department has radiation that's a concern for them, as well as there are a number of chemicals now that we can use to trace things in the body, and they're radioactive as well. So the key with radiation is it's all about dose. You can either have one large dose of radiation just once, even for a very brief second, and that the cumulative effect of that may be fatal, or you can have small doses over time kind of add up. So like in radiology departments, you'll usually see them have a little badge that has a color on it. When that color turns, it means that their radiation exposure for the year is done, so they have to be somewhere else. Doesn't usually happen if all the equipment is right. Radiation, just like in cancer therapy, it affects cells that are dividing rapidly. So the epithelial tissues in the GI tract, as well as the skin and hair, bone marrow, you get bone marrow suppression with radiation. The digestive tract kind of falls apart because it depends on rapid cell turnover. And then the gonads. Sterility can result from radiation exposure because it halts that cell division. All right. Noise is another environmental factor. Again, like so many of these, you can get in trouble with a lot real fast or a little over a long time. So a sudden, very loud noise can damage the tympanic membrane. It can damage the nerve cells in the ear, even if it only goes on for a very short amount of time. So this would be, if you suddenly found yourself behind a jet engine, for example, it can cause permanent damage to your hearing just for a short amount of time. More commonly, what we see is cumulative noise damage. So exposure to loud sounds a little bit over a career, for example, it knocks out first the high and low pitches, so you can't hear highs or lows, but then eventually it works its way into the middle of our auditory spectrum, and then you have trouble hearing voices and things like that. Hobbies are included in this, so like, if you're an avid rock concert goer, if you're a shooter, shooting range, that's loud sounds repeatedly over time. Many hunters will say that they're deaf from all their hunting, and they're not wrong. So the key is prevention. You can't grow hearing back. You can only keep yourself from losing it. So loud hobbies or loud workplace environments, ear protection, ear protection, ear protection. All right. And then I think this is the last one. Here, come back here. Biologic agents. I'm not talking about infection here. I'm talking about things living things have made. So, for example, venoms would fall into this category of biologic agents. So, these are your scorpions and your rattlesnakes and all those creatures we share the earth with. They can have a variety of different effects. Remember, the venom was designed to hurt animals. I mean, that's what it's for, either for food or for protection. So they can be nasty. They can cause paralysis, seizures, necrosis. Spider bites, for example, the purpose of the spider venom is to digest and dissolve its prey. So it does the same thing to our tissues too. Infectious agents, we already talked about that. And then allergic reactions. Like a bee sting shouldn't be a big deal to a big organism like the human being. But if you're allergic to that venom, then that can in turn become an even worse problem. All right, so that's it for the short chapters. We start next time. We're not going to do the question because it's time to quit.